All right. So, good evening, everyone. I'm Dr. Tushar Mehta, orthopedic surgeon and your faculty of orthopedics. And this YouTube live session is basically for the discussion of the orthopedic questions that were asked in INICET November 2021. Before I move further, there's a lot of hue and cry which is going on. I encountered a couple of memes also about the orthopedic questions that came in this exam. First thing I want to clarify that yes, the contribution by the subject in the number of questions is definitely high. There is no question asked about it. But what I'm trying to tell you as well is, the difficulty level was not that much. You will find that in next about 20-25 minutes from now. क्वेश्चन का नंबर जरूर ज़्यादा था, लेकिन क्वेश्चंस उतने मुश्किल नहीं थे जितना आप लोग सोच रहे हो. एंड we'll find it out and we'll sort it out. I will be more than happy and pleased if anyone out of you can just correct me with the options and help me, collecting the options and match it. First question. As of now, based on the recall that I got from you all, the question starts like this: that a patient sustained fall from height. He was treated with a cast. What fracture he had? No mention. What cast was applied? No mention. Which was the site where cast was applied? According to recall, no mention. But yes, it is mentioned that he had a fall from height and he was treated by some cast. Now, after removal of the cast, after removal of the cast, he was not able to walk properly. Some issues with the lower limb, maybe related to hip. Some issues with the gait, and not able to lift leg, and he kept dragging. Two things. There are two possibilities. A, he had a high steppage gait. B, he had something which we have discussed so many times. In every lecture of orthopedics, whenever hip joint starts, we start with what? Anatomy. In anatomy, we start with what? An MCQ. That MCQ is on what? Trendelenburg mechanism. What do I explain? That if you are standing on your right foot and if your left foot is in the air, then abductors of the right hip, gluteus medius minimus of the right hip, supplied by superior gluteal nerve of the right side, they will contract basically to lift the left pelvis up, to raise the left pelvis up, because of which the left foot will have the ground clearance and it will be able to cover the swing. Simultaneously, it happens vice versa, and then we talk about Trendelenburg gait, we talk about abductor gait, lurching gait, lurch, and then we compare it with limb. Every time we start anatomy of the hip joint with that. So he's not able to walk, he's not able to lift his leg, he's dragging his limb. And what students told me and what message I got, that there was some image, maybe some cadaveric image or something, where they were supposed to mark the muscle. So we know that we are talking about Trendelenburg gait, we are talking about abductors, we are talking about gluteus medius, we are talking about gluteus minimus, and we definitely are aware of this fact that this gluteus medius and minimus, which are supplied by superior gluteal nerve, are basically the abductors of the hip, and they're responsible for the abductor mechanism. So this kind of an image was given and abductors were supposed to be marked, gluteus medius was supposed to be marked, and the answer is gluteus medius. It is not gluteus maximus, it is not piriformis, it is not quadriceps, but one catch is there, that you can talk about foot drop. One catch which I feel, that if the question mentions something about foot drop, then ideally answer should be sciatic nerve. Now, whether sciatic nerve was in the option or not, that's the catch. As of now, all recall that I have got from many of you, sciatic nerve, nobody has mentioned that sciatic nerve was in the option. In fact, somebody messaged me that it was not quadriceps, it was quadratus femoris. So whether it was quadratus femoris, whether it was quadriceps femoris, that doesn't make any difference to my answer. It is not piriformis, it is gluteus medius. Now some people say the other option is gluteus minimus or gluteus maximus. If it is gluteus maximus, the answer is simple, it is gluteus medius. Even if the other option was minimus, then the answer would again be medius, because medius contributes more. So this is the first question. Do you find it difficult? on a scale of difficulty 2 out of 10, because we have already discussed every time this question, this concept, this thing in our lectures, where not only I tell you about the Trendelenburg mechanism, the lurch limb, I even walk in front of you and I show you what is lurch, what is limb, what is painless, what is painful. Lurch trunk deviates towards the disease side, limb trunk deviates towards the painful side. We have always discussed this question. Second question, allegedly a difficult subject. Everybody is talking about orthopedics, but now let's see. First question, on a scale of difficulty, on a scale of 10, it is hardly 2 out of 10, and most of you got it right. Now let's talk about the second question. In bone tumors, don't you think that every time I've told you that in osteoid osteoma, initially we give a trial of aspirin? Yes, because aspirin is a salicylate. Salicylate is non-steroidal anti-inflammatory drug whose mechanism of action is basically inhibition of prostaglandin synthesis. And then I tell you that majority of the cases are treated by low-dose aspirin, and this is how I say, and if that doesn't work, then we do radio frequency ablation. What happens in that we have a radio probe and we put that onto that area for certain not accessible area, and we put it over there and we go like brrr, and it kills the tumor cell. So osteoid is treated with radio frequency ablation. There should not be any confusion. Simple bone cyst, as we say, that it is less of a neoplasm, more of an inflammation because it is having more of a reactive exudation of the fluid, and it is an inflammatory pathology. And to treat an inflammatory pathology, the best thing which is required is anti-inflammatory. And what is a better thing apart from steroids as anti-inflammatory? Steroids are the best anti-inflammatory. In fact, I usually mention the steroid also. It is Canacort, it is triamcinolone acetate, and what we do is we put that steroid into the tumor, into the lesion. Simple, straight. Osteosarcoma, is that a simple tumor? Is that a benign tumor? Is that an aggressive tumor? No, it is an epitome of malignancy. I always mention कि malignancy का बाप है. It is an epitome of malignancy. Do you treat malignant tumor with curettage? No. You always treat osteosarcoma, and I have already told you that we take 10 centimeter above and 10 centimeter below, and we do wide excision. GCT, we always mention that we kind of do an extended curettage, and then we put a autograft, that is your own graft, or allograft, that is from the bone bank. So very simple question with very simple answers. We had discussed almost all of them. There was nothing, again, on a scale of 10 difficulty level, hardly 2 out of 10, nothing much. Majority of the tumors were already covered. 2 questions till now, not so difficult. Third question. Now, radial nerve, everybody knows, has to do something with the wrist, producing wrist drop. Can you see any wrist drop here? I don't see. Musculocutaneous nerve supplies biceps brachialis and brachioradialis. Musculocutaneous does not even come closer to hand, so it cannot be the answer. Now, answer is either ulnar or median. Now we know that these are 3.5 are supplied by ulnar, and this 1.5 is supplied by median. Now if you see, then this is clearly an image of a partial claw hand. There is no confusion at all about it. This is a clear-cut image of a partial claw hand. It is somewhat like this. Partial claw hand. So you can see the image which was given probably was not a similar image, but it was a lateral view which was given. Now you can very well see the hyperextension at the MP joint. You can see the flexion at the PIP and the DIP joint, particularly of these 2 fingers. Ulnar nerve is important. Ulnar nerve supplies these tendons, these flexor tendons, and these lumbricals and introtia. So everything is going in very clear favor of ulnar nerve. So again, there should not be any confusion. On a scale of difficulty, maybe 1.5 or 2 out of 10. We have discussed 3 questions. Until now, not even a single question was something like which you guys are telling all the time, messaging me that it was something out of the box. No. Yes, this is one question which is important, which is Thomas test, and they have spoken about sequence of it. Now, first we'll try to understand what is Thomas test. See, please try to understand, if your hip gets diseased because of any pathology, if your hip gets diseased because of any pathology, that can be tuberculosis, that can be any other anomaly, that can be anything. So whenever there is a damage to one of your hips, The body is so compensating, the body is so kind that when that hip, because of that pathology, goes into a flexion deformity, to compensate for that, the opposite hip also starts going into flexion. And when both of them go into flexion deformity, then spine comes to play a role, and it compensates how there is a spinal curvature called lumbar lordosis. The spinal curvature of lumbar lordosis gets exaggerated. As simple as that. So first thing which is required is, to perform Thomas test, you have to have a flat hard bed. There should not be even a bed sheet. Forget about the mattress or the cushion. So there should be a flat hard bed. Now, after flat hard bed, you have to put your hand under the lumbar spine. Your palmar surface of the hand is touching the lumbar spine. That means there is no lumbar lordosis. Lumbar spine is exactly straight. Now what you do is, you ask the patient to flex the contralateral hip. You ask the patient to flex the contralateral hip on his or her own. So you can very well see that this is the flexion of, contralateral hip on his or her own. This is the flexion of the contralateral hip by the patient on his or her own. First thing what you did, do you remember? This is the second step. What is the first step that you did? You insert your hand behind the back. To check for lumbar lordosis. Okay, this is the first thing. Second thing is this. Now, what is the third thing? Third thing is you have to just observe. What do you observe? You simply observe one thing. That means you will see that the moment he will start flexing the contralateral hip on his or her own, this knee will rise from here. And if you see, then this is, I should be using a white line. This is the plane of the bed. Alright, so this is the, okay, I'll use it in a different thing. Yeah, so this is the plane of the bed. This is the plane of the thigh. And the place where these two lines meet, this is the plane of the thigh, and this is the plane parallel to the bed. Now this angle that you get is basically a value, or you can say an angle of FFD, fixed flexion deformity of the hip. So first thing is, Thomas test is given by Dr. Hugo Thomas. It is performed for hip joint. It calculates fixed flexion deformity of the hip. How do you do that? You make the patient lie down supine, remove mattress or even a bed sheet, put your hand behind the back and check for the lumbar lordosis. There should not be any lumbar lordosis. Then ask the patient to flex the contralateral hip on his or her own. Then you will see that the hip that you are going to examine automatically goes into a particular amount of flexion, from which you can flex it further, but you cannot extend it. That is the definition of fixed flexion deformity, and the angle that you measure is basically the value of that. So I would, first of all, what is the first step? The first step is always this. This is the first step. This is always the first step. The second step is that you have to overcorrect the normal side. The third is basically you have to flex the hip. There is no concept of squaring of pelvis, but I got messages that there were certain other options also, but nobody is able to recollect what was the exact statement in those options. So maybe if you can help. But I have told you something about Thomas test, which actually helps in calculating the fixed flexion deformity, whether it is there or not, and then if it is there, then what is the value of it. Again, something, okay, fine, I understand, on a level of difficulty, on a scale of difficulty, 6 out of 10, 7 out of 10, I agree that this was something which was out of the syllabus, although we had discussed in most of the batches. Now let's talk about this question. I mean, this is something which has been coming for almost last half a decade, and every time we get it right, because there's a 60-year-old lady they have mentioned, post-menopause they have mentioned, and some students told me that all these comorbidities were mentioned, that she is a non-smoker, diabetic and hypertensive. Then they had mentioned that she has Colles fracture, which was when she was 52, probably 8 years ago. So this is the kind of statement that I could combine and accumulate after getting feedbacks from all of you. And then there is a DEXA scan of less than -2.5. What else bloody one needs to call it, and a lady suffering from osteoporosis? Or kya chahte ho? क्या चाहते हो वो खुद आके बताए कि मैं कौन हूँ और मुझे में क्या करना है. Now in osteoporosis, HRT has no direct role as far as the drug of choice is concerned. Calcium, vitamin D in osteoporosis, I'm sure you all are aware of it, that calcium is normal, phosphate levels are normal, ALP levels are normal, so there is no question about it. Now repeat DEXA after 3 years. पहले कुछ दे दो दें. First let us start some treatment. Okay, DEXA is not less than minus 2.5, it is minus 2.5, then it will be osteoporosis. So repeat DEXA after 3 years, and plus most of all 3 years. Why would somebody wait for 3 years? Elandronate, and somebody mentioned that elandronate stat was the option. Stat was there or not, doesn't matter. The answer is bisphosphonate. Drug of choice is bisphosphonate for any sort of osteoporosis and any sort of patient, except for the patient which is resistant to bisphosphonate on a scale of difficulty, hardly bloody 1 out of 10. I mean, everybody knows, yeah, drug of choice for osteoporosis, whatever fancy, whims and fancies they show in the question, answer has to be bisphosphonates. Not at all difficult. Okay, even if it is 3 months, nice. Even if it is 3 months, doesn't matter. Even if it is 3 months, Mr. Nazar, doesn't matter. NZR, so answer will be bisphosphonates. Moving over to the next question. A patient presents with femoral shaft fracture. Definitely, if there is a femoral shaft fracture, you have to put a skeletal traction in the tibia. So a patient has fracture of the shaft of the femur, and there is a tibial traction which has to be applied. What all are needed? Do you remember a pin which is blunt on one end and pointed on another end, which is having a diameter of 4 to 6 millimeter and quite solid, which is the most common implant for application of skeletal traction? Yes. Do you remember a wire which is hardly 2 millimeter in diameter, which is quite thin, which is pointed on both the ends? But the most interesting aspect is that it is used only for short tubular bones like phalanges or metacarpals. K-wire. Where are you putting traction here? Tibia. Do you think K-wire is for tibia? No, it is only for short tubular bones. And when I say short tubular bones, that simply means phalanges and metacarpals. It has nothing to do with tibia. One option was Dunham pin. Now many students messaged me, it was not Dunham's pin, it was Durham's pin. Actually, you know what? It is, the correct terminology here is Dunham's pin. There are some oldies, I mean there are some senior professors who have a habit of not calling Dunham, they call it Durham. It was not Durham. I mean, okay, fine, if they mentioned Durham, that's okay. By Durham they meant nothing but Dunham. Do you remember a pin which is again blunt on one end and pointed on another end with 4 to 6 millimeter diameter, which has grooves in the center, which is used for application of skeletal traction and cancellous bone like calcaneum? Does that sound similar to you? कभी लगता है ऐसा पहले पढ़ा हुआ है? हमने पढ़ा हुआ है. We have discussed this in almost all the lectures. In the workbook also it is given to you as an image. Thomas splint. Come on, Thomas splint is used to stabilize a fracture, not to apply traction. Bowler stirrup. Do you remember something like this, like this, like this, like this? Whether you put Steinman or Dunham or anything, that has to be connected by Bowler stirrup. Do you remember? Bowler bronze splint. In fact, the image which is given in the workbook, in that the patient lies down, he is lying down on the bed in this sort of a frame which has a pulley A here, which has a pulley A here, which has a pulley B here, and which has a pulley C here. So it has a pulley A, a pulley B, and a pulley C, and it is on the bed. So this is what is called as Bowler-Brown frame or Bowler-Brown splint. Very simple. Is that clear to all of you? Done, everyone? Okay, we have a question, sir. Both pins, I didn't get you. You can use Steinman, you can use Dunham. Yeah, you can use Dunham also. Although we don't use it majorly in tibia, but yes, it can be used in tibia. K-wire cannot be used in tibia. Okay, we are talking about can be used. Next question. I honestly, I got the messages after the exam. It was so tough. So, I mean, what was tough? I still don't get it. Now, what about this question? Don't you think it is quite easy? because we all are aware of the fact that there is a central cylinder called as axon. On the top of it we have a myelin sheath, then we have endoneurium, then we have perineurium, then we have epineurium. If you damage all of them, we call it neurotomesis. If you damage only the axon but sheath intact, axontomesis. If you doesn't damage any of them but just transit demyelination, we call it neuropraxia. In all the lectures we have discussed spine. In spine we talk about peripheral nerve injury. If you remember, we talk about Seddon's classification, and don't you think we talk about neuropraxia, axontomesis, and neurotomesis? So a complete anatomical conduction block. So when we talk about complete axon plus sheath block, when we talk about complete axon plus sheath block, it is neurotomesis. When we talk about axonal block but sheath intact, when we talk about axonal block but sheath intact, it is neuropraxia. When we talk about a physiological conduction block, it is neuropraxia. The fourth option I was not able to recollect at all. Somebody mentioned axonpraxia. Somebody mentioned it to me, sir, it was probably axonpraxia. So I said, okay, fine, whatever, blah blah blah. So very simple question with a very simple answer. I will not even put that on a difficulty scale. There is no point. Now, compartment syndrome, a topic which is asked almost every alternate time. A patient with tibial cast presents in emergency room. ठीक है जी, cast removed, wonderful. Pain on passive flexion. Yeah, somebody mentioned it. Somebody mentioned that this option was axonpraxia. बड़ा अच्छा लगा मुझे सुन के axonpraxia. Anyhow, so tibial fracture, wonderful. Cast removed, over, wonderful. Pain on passive flexion. Don't you remember this? Actually, it should have been pain on passive extension, not flexion. Now, what do you think? This is what is called as stretch test, yes or no? Yes. So this is what is called as stretch test, yes or no? Yes. Now, when we talk about this stretch test, don't you think it is the most important physical sign for this condition called as compartment syndrome? What do you think? This compartment syndrome, stretch test is talking about compartment syndrome. Yes. Dorsalis pedis and posterior tibial artery present. DP, dorsalis pedis and posterior tibial artery present. We are not concerned about pulse, boss. Pulse is not a reliable criteria. This is a reliable criteria. It is the most specific sign for the diagnosis of compartment syndrome. Loss of sensation in first web space. Okay, fine. Some paresthesia is there. Next step. Is this compartment syndrome? Yes or no? Yes. So in compartment syndrome, just giving painkillers will help. Forget it. Reapply cast so that more compartment can happen. Forget it. Pulses are present. Bloody hell, why do you want to confirm with a Doppler? You have to measure the pressure, and the diagnostic compartmental pressure value is more than equal to 30 millimeter of mercury, although that is something which we don't do often. What we do often is we take stretch test. If that comes out to be positive, we immediately shift the patient for surgery, and that is what we do is fasciotomy. Simple question, simple answer. Again, why can't you, why do you call them tough question? Compartment syndrome, we knew this. This axontomesis, neurotomesis, we knew this. Implants for skeletal traction, we knew this. Drug of choice, we knew this. I agree. थोड़ा सा bouncer हो जाता है, I agree. Claw hand, we know this. Treatment, we know this. Trendelenburg, we know this. Even if pain on movement, Pawar Saab, even on pain on movement is there, or pain on extension is there, whatever is there, or ecchymosis is there, it is compartment syndrome. There is no question asked. They have told you tibial fracture, they have told you cast, they have told you pain on passive movements or whatever extension. So, कोई सवाल नहीं है इसमें, मतलब confusion नहीं. Now, this is something, okay, fine, I understand that it is about the stability of the external fixator. So, let's talk about that. Now, this is basically a fracture. This is basically a fracture. Now, what I'm trying to tell you here is that if you put a Schanz pin here, okay, so if you put a Schanz pin here, okay, you have put a pin here, you have put a pin here. Now, if you connect it with a single rod, this is uniplanar with one rod. So right now, this is uniplanar with one rod. Okay? This is uniplanar with one rod. Now if you put another rod on the top of the rod, if you put another pin on the top of the rod, like you put another rod here, you put another rod, so there is one rod here, okay, so there is one rod here, there is one pin here, so this was uniplanar with one rod. Now this is uniplanar and you connect these two rods, then it becomes what? It becomes uniplanar with two rods. Definitely it gives more stability because you have two supporting rods, two lateral supports. Now if I put something here, I put another shank spin on this side, I put another shank spin on this side, and if I connect another rod here, then it will be called as biplanar. So it will be called as biplanar. So definitely if you are supporting from the opposite side of the fracture also, it has more stability. So biplanar has more stability than uniplanar with two rod, which has more stability with uniplanar with one rod. Now I bring the BAP of fixators. Now I bring the BAP of fixators. What is the BAP of fixators? That you put small wires and you connect them with semicircular frames. You connect them with semicircular frames. So this is supporting almost circumferentially. Are you able to understand? So it is supporting almost circumferentially. It is not a 2D thing, it is a 3D thing. Lateral rods are in 2D, but a circular support is by 3D. So definitely in terms of lowest to highest or highest to lowest, whether you talk about lowest to highest or highest to lowest, this is highest, this is second highest. In terms of stability, this is third highest, this is fourth highest, or you can say lowest. If you're talking about lowest to highest, then A, B, C, D, correct. This is the right answer. Are you able to understand this? Now Benedict sign is something, Pope sign is something that you have a hand like this and you try to flex your fingers, you are able to flex it, you are able to flex it, you are able to partially flex it, and you are like this. This is Pope sign. Okay? In Pope sign, in Benedict sign, in pointing index, you try to flex it. And when you flex, you are able to flex the little finger, the ring finger, partially the middle finger, and you are left with a, you are not able to flex the index finger. So that is basically Pope sign. You will not observe any hyperextension at the metacarpophalangeal joint as you saw in the ulnar claw hand. In the ulnar claw hand, patient will not make an attempt to flex. Patient will come directly like this, with hyperextension at MP joint, with flexion at PIP and DIP of index, middle, index ring and partially middle finger. Okay, second question after that, Thomas, which I can make it out ki haan chaliye theek hai, there's a lot of stress and a lot of anxiety when you're solving that paper. You have a very limited time. There I can understand, yes, it is allegedly a difficult question, but honestly there was nothing much. It was just a hue and cry which everybody was saying time and again. मुझे नहीं लगा इतना कोई rocket science paper था, because I mean, Trendelenburg, we have discussed, we are aware of the abductors, gluteus medius, minimus, superior gluteal nerve. We know about steroids, we know about RFA, curate excision, we know about partial claw hand, we know about, okay fine, we understand Thomas test, maybe steps were a little difficult, we know drug of choice osteoporosis, we know Steinman, we know Dunham, we know K-wire, we know Bowler stirrup, we know Bowler Brown splint, we know Thomas. This though was just a cakewalk, and compartment, as everybody is aware of it. So again, this was something which probably could have been solved with a common sense. But anyhow, whatever it was not that difficult as you guys perceived it to be. But yes, the contribution of questions from orthopedics was way above than what you had expected. I have not expected this. I always tell you that though it is considered to be a minor subject, but at times when you combine it with anatomy and radiology or maybe some sort of medicine also, the number of questions that come are usually often. So now what I'm trying to tell you is again that this paper probably gave you a kind of a hint that the pattern is going towards the clinical questions, the pattern is going towards the clinical subjects, even though they are minor, but still they are contributing a lot. And the management part is more focused upon, and I think that really helps to most of the people. I remember I got a message on Instagram from one of the students that, sir, I had mugged up so many tables and there were no direct questions from the tables. I don't know whether you remember this or not, that in every face-to-face lecture that I take, I always mention that all these tables and all these list of one-liners, they are important to make a probably just to make a concept, but they are not going to be there. I mean, what I've seen is most of the students during the last couple of days of revision, what they do is they tend to revise those tables thinking that, okay, fine, I don't have the time to revise the whole subject, so I'll just go through that. This is not going to help you. Even when I take a lecture, I take them towards the end of my lecture. Just towards the end, when I'm about to finish, I just immediately quickly say, okay, fine, this is most common, least common, tallest, shortest, smallest, largest. I never take that as this thing that, okay, fine, this is the most important, we have to focus more on that. We have to focus more on the clinical aspect of the subject, and that is something which is going to take you ahead for your coming NEET PG in March also. So very limited time for NEET PG, and I think you guys are giving your more than 100% to prepare for NEET PG. If there is still any doubt, you can put it on Instagram or any of the social media. I'm there on almost all of them. Instagram is quite handy these days, so anything, just feel free. Apart from that, if there is any query, you can mail it to me. I'll be more than happy to sort it out as soon as possible. Apart from that, you can message me on Insta also. I will try to help as much as I can. If still there is anything which is left, you can WhatsApp me on this number. I'll try to sort it out for you. So thank you so much, and I wish you all the best for the NEET PG exam. Do well, study well, make a plan, follow it. Thank you so much. Good night. God bless. Bye-bye.